Hello again, Pharmacology 1, and this lecture is going to cover chapters 9, 10, 11, and 12. So these are all anti-infectives of one type or another. We're going to start with chapter 9, which is fluoroquinolones. Okay, that's a classification of antibiotic. And the one that you got to know about is ciprofloxacin, also known as cipro. There are other fluoroquinolones, and with this classification, the commonality is oxacin, ciprofloxacin, gemafloxacin, levofloxacin, moxifloxacin. You get the picture. But the one that I really want to concentrate on, and they all share commonalities, cipro, cipro, cipro. So what do you need to know about ciprofloxacin? You don't need to know the mechanism of action. No one is going to really ask you about that. But what's it used for? Cipro is used for pretty broad types of infections, gram-positive and gram-negative bacteria. Respiratory infections, usually lower, like pneumonia. Bone infections. Anthrax, believe it or not, which is biological warfare. Urinary tract infections. When we talked about chapter 6 and the sulfonamides, sulfamethoxazole trimethoprim, which is a sulfa drug, is used to treat urinary tract infections very, very commonly. Ciprofloxacin, which is a fluoroquinolone, is also used very commonly to treat urinary tract infections, also skin infections and some other things too, but you'll see it very commonly used for UTIs. When we talk about adverse effects, remember what I said in the previous lecture. All antibiotics can cause GI upset, nausea, vomiting, diarrhea, okay? Fluoroquinolones can cause photosensitivity. So you're going to tell your patient, wear sunscreen, stay out of the midday sun, wear a hat, right? But there's one thing that you definitely need to know about the cipro. That can cause tendinitis, actually Achilles tendon rupture. So tendons are rubber bands, kind of, that actually connect bone and muscle together. The Achilles tendon, in case you don't know the story of Achilles, let me tell you. So Achilles was the son of a Greek goddess and a mortal. So she was, knocking boots with a mortal. They usually don't do that. They stick with their, other gods and goddesses. Anyway, so she had a son named Achilles. And because he was half mortal, he could die. And gods and goddesses never died. So she took her baby Achilles down to Hades, the land of the dead. And there's a magical river there called the River Styx. And she held Achilles by his heel upside down and dipped him into the magical water of the River Styx. Pulled him out. Once you're dipped in that water, you are impervious to harm. In other words, you could get shot, stabbed, whatever. You don't die. But one part of him didn't get dipped. It was his heel, because that's how she was holding him when she dunked him. That is Achilles' heel or Achilles tendon. So that tendon is the one that connects the heel bone, the calcaneus, up with the tib-fib, right in the lower extremity. And so cipro can cause it to spontaneously rupture and disconnect from the bone, which is very bad, by the way. If your patient is prescribed cipro, you would want to find out if they like to run or jog, because you would advise them not to do that while they're on the cipro, because that would increase their risk of Achilles tendon rupture, which, by the way, if it does happen, it is a long healing process, 6 months minimally. Also, the other things that antibiotics can cause, like bacterial or fungal superinfections, candidiasis, and also pseudomembranous colitis leading to C. diff, which is that liquid frequent diarrhea that's tinged sometimes with mucus or blood and that kind of thing. If the patient should report after starting cipro a new onset of any kind of like calf pain, Charlie horses, stop the drug, call the healthcare provider. Well, that can be an early sign of the Achilles tendon rupture, and that's bad. You don't want them to have that. When it comes to cipro, scroll down definitely go through, I'm on page 10 or slide 10, where it talks about, of course, nursing process. So you want to make sure, and this holds true with all antibiotics, always get a culture and sensitivity before the first dose of any drug is given, any antibiotic. Because if you give the antibiotic and then do the culture, guess what's going to happen? The culture is going to be skewed by that antibiotic. And with the fluoroquinolones, with cipro, you want to make sure that you're checking liver function, renal function, also a CBC, and a urine analysis to make sure that there's no contraindications for the patient having this medication. There's some nursing diagnoses also in this slide. Talks about pseudomembranous colitis towards the end and has a couple question and answers there. The things that I've highlighted are the things that you want to focus on, okay? And that's going to be it for Chapter 9. So we are now going to move on to Chapter 10. Chapter 10 is the anti-tubercular drugs, so drugs that work against tuberculosis, which you remember is an airborne disease. Remember, I want my MTV, measles, tuberculosis, varicella, airborne. So tuberculosis. 2 drugs in this group you must know. Isoniazid and rifampin. And when you see rifampin, remember, R rifampin, red. Rifampin is one of those meds that will turn not just urine an orange-red color, but all body fluids. So saliva, sweat, even tears. Imagine if you're not prepared for this and the doctor starts you on rifampin and you're home that night and you're watching a sad Lifetime movie and you start to cry when you get a tissue, it looks like you're crying blood. So you make sure that you instruct the patient so that they have an understanding that body fluids, urine, sweat, saliva, tears, are going to be discolored to an orange reddish color, okay? When we talk about TB, there are a couple things that I want to bring to your attention so that you understand these concepts forever and ever. Number 1, when you are exposed to tuberculosis, okay, we know that we all get a test called the PPD, Purified Protein Derivative. So that's the test that all of you got. Maybe a 2-step, maybe a 1-step. You went in and the nurse or the doctor got a little needle, very, very small gauge needle, and did an intradermal shot right here, usually on the inner aspect of the forearm. And they made what's called a little bleb. And so that purified protein derivative went under your skin, and you were told to come back in 48 to 72 hours so that it could be read. So what are we looking for? Well, when you went back to have it read, we're not really looking for erythema, redness. What we're looking for is a hardness, a lump, a swelling in duration. And you would feel it. It feels like a little pea under the skin where the bleb was placed. Anything 10 millimeters or larger is considered a positive reaction. Doesn't necessarily mean the patient has active tuberculosis, but once you've been exposed to tuberculosis, you will always have a positive PPD. So you'll never get a PPD again, okay? So at that point, if it reads positive, the doctor would send that patient to get a chest x-ray to see if, in fact, is it active tuberculosis? Were they exposed previously to tuberculosis, right? It can show scar tissue and so on in the lungs. If it's active tuberculosis, usually 4 different medications, minimally 2. Never just one med to treat TB. Why? Good question. Because tuberculosis is a bacterial infection. And the M. tuberculosis bacillus, which is the bacterium that causes the infectious process, actually has mutated over time, like many bacteria do. MRSA, VRE, right? And so because of the fact that it's mutated, we always treat with more than one drug to make sure that we're getting the bacteria from every angle that we can. Does that make sense? Okay. And so active tuberculosis, we're always going to be using more than one drug, minimally 2, okay? If we're doing a retreatment, in other words, they've been treated, but it's reared up again and we need to treat them again, it's definitely going to be 4 or more drugs, okay? The slide On page 4, slide number 4 talks about the different phases. Really don't worry about that. Just understand that standard treatment's 2 drugs, and that's important for you to know. It's also important for you to know about adverse reactions. So with almost all the antitubercular drugs, nausea, vomiting, epigastric distress, which means at the area of the stomach. It's like indigestion, fever, skin eruptions. That can be hives, pruritus, urticaria, itching, hives, and also, larger than that. Hematological changes. Again, we talked about that a little bit before. So, we'll talk about what labs we need to review before we would administer these medications. The liver. Remember, drugs, when they're taken, are going to be excreted by either the liver or the kidneys. Okay? If the patient were to become toxic, and now we're talking about isoniazid specifically, in other words, they're high levels of the drug, they can start to develop peripheral neuropathy. Peripheral means extremities, and it usually is the feet, lower extremities, and neuropathy, neuro meaning of the nervous system, and apathy or pathos from the Latin word pathos, which is, a dysfunction of. So tingling and even loss of sensation at the periphery, at the feet, lower extremities, even hands and toes. That can be severe, where it can progress to being fatal, where there can be such intense nerve damage. That's important for you to know. Every drug, I know every slide in every category will always say if the patient is hypersensitive, obviously if the patient's allergic to the drug, don't give it to them, right? That makes sense. Okay. That's why I don't get into that, because that's the same every time. Number 8 talks about the generalized reactions with rifampin. Again, nausea, vomiting, epigastric distress, heartburn, fatigue, reddish-orange discoloration of body fluids. And of course, rifampin is hard on the kidneys. So you want to make sure that we're doing BUN and creatinine levels before we're giving it. And if we know that the patient has any renal impairment, in other words, problems with their kidneys, you might be very cautious in giving them this drug. Understand that this drug is nephrotoxic, in other words, can be toxic to the kidneys. Also ototoxic, can be toxic to the hearing. Lots of drug-drug interactions. This is not a drug that you're going to see commonly. And I promise, if you get a question about rifampin, it's going to be about the orange-red body fluids. That's the most common question that there is. Or about using more than one med to treat. Always at least 2. And really, that's about it. I mean, certainly you can go through and look at the other slides that talk about the nursing process and, patient and family education, et cetera, et cetera. But definitely take a look at slide number 23 and 24. Talks about preventative therapy. So if you're exposed to tuberculosis 6 months to a year, you heard me right. Just by being exposed, that's not even active TB. If you've been exposed, you're going to be treated prophylactically, preventatively, for at least 6 months up to a year. And prophylaxis is one drug. So prevention is one drug. Retreatment or treatment, 2 drugs, 3 drugs, 4 drugs. And that's it for tuberculosis drugs. And now we're going to move on to Chapter 11. And Chapter 11 is the virals, antiviral medications. And I'm going to make this one super, super easy. Antiviral medications, the one that I gave you to look up in F.A. Davis, should have been acyclovir. And here's the nice thing about the antivirals. If you look at the name acyclovir, V-I-R at the end, virus, right? Sometimes classifications of drugs have a clue embedded in their name that can kind of help you figure out what they are. Not always, okay? Sometimes it works and sometimes it doesn't. Anyway, so antivirals, well, what do they fight? You got that right, viruses, viral infections. Don't worry about how they do it. Like I said, you're not going to be pharmacists. No one will ask you about the mechanism of action. But I do want you to take a look at slide 4. Talks about labeled uses. To be clear, a labeled use is what the drug was made to do. That is the use that's on the label. In other words, we created this antiviral for these viruses. And you see that they have here cytomegalovirus. Don't worry about that one so much. When you get to term 5, we talk about HIV and transplants. You'll learn more about it. But HSV, which is herpes simplex virus 1, which is like the cold sores that you get around the mouth. Some people get those chronically. And 2, it's the gift that keeps on giving, genital herpes. Herpes zoster, which is the shingles, okay? With the herpes antivirals, including acyclovir, cannot stop the disease. So they don't just kill the virus. But what they can do is, if they're taken like as quickly as possible at the onset of the symptoms of the virus, they will slow the progression down and shorten the duration of the virus. And it also includes HIV, the flu, A and B, RSV, which is respiratory syncytial virus. You're going to learn about that when you get to peds, right? And the hepatitis is B and C. Don't worry about unlabeled uses. No one is going to ask you about those. When it comes to adverse reactions, you're going to be shocked when you hear this. And I'm looking at slide on page 5. GI upset, nausea, vomiting, diarrhea. I mean, almost every medication out there has the potential to cause those things. So make sure you're aware of that. But you want to make sure that you're being cautious if you're using antivirals in patients with any kind of kidney problems, renal impairment, low blood cell counts. In other words, are they anemic or thrombocytopenic? So do they have low red blood cells and low hemoglobin? Do they have low platelets, or are they neutropenic or leukopenic? They have low white blood cells, okay? If they have a history of epilepsy, you want to be very cautious too, because of the potential for neuro involvement. And if they have any history of respiratory disease, chronic, like, bronchial asthma, you want to be careful. You don't need to go through all of these different interactions with very specific antivirals. Like I said, I just want you to be familiar with acyclovir and understand what it is, what it's used. It's an antiviral, what it's used for, slows down and shortens the duration of certain viruses. And really, the same thing as far as adverse reactions, GI upset, et cetera, et cetera. Look at the nursing diagnoses. Just so you kind of have an idea. I highlighted on slide 11, body image disturbance, and I highlighted that one for a reason. If people are subject to chronic herpes simplex 1, which the cold sores, and when I say chronic, sometimes people get these constantly. They're gonna sometimes be feeling some type of way about how they look. So definitely keep that in mind. As nurses, we are holistic. And what that means is we're not just taking care of the disease, like you had the herpes. You got the herpes. No, you're a person. And we want to make sure that we're emotionally and psychologically, holistically, we're caring for the whole person. Okay, so don't forget about that. And I am pretty sure that in this classification, that is about all I got. Yep, so there you go. Now we're done with 11, and 12 is going to be quick too. So in your farm book, chapter 12 is all about antifungals. And first thing I like to tell you, there's a fungus among us. Get it? A fungus among us. Anyway, all right. When it comes to antifungals, there is one that you gotta know. I'm going to talk about some of the others, but this one, nystatin, swish and swallow, and I'm going to actually put that swish and swallow. What does that mean? Well, nystatin is an antifungal, and it's used to treat candidiasis. Candidiasis, the oral thrush where you get the white plaque buildup in the mouth and the throat. By the way, candidiasis is painful. If you were to take a cotton-tipped applicator and take the cotton tip and touch to one of the little white plaquey things inside the oral mucosa, it would bleed. It would ooze little droplets of blood. So, I mean, it's a fungus. It's attached into the oral mucosa. Nystatin, swish and swallow. You take a swig, retain it in your mouth. In other words, swish or just hold it there and then swallow it. So make sure you know that. Candidiasis is nystatin, swish and swallow. And I got to tell you, so many students have gotten a question like that on their boards. So don't you forget it. All right? All right, that's nystatin. So antifungal drugs, I am not going to get into a whole lot about that because really, even for the protozoal infections and the helminthic infections, you're not going to get questions about that. So for this chapter, and guess what we are? We're going to be done right now. Just remember, candidiasis is nystatin, swish and swallow. The other antifungal drugs, okay, do end, not all of them, but a lot of them, in ZOLE, okay? Ketoconazole, miconazole. But here's the problem with that. There's another classification of drug called proton pump inhibitors that are used to decrease stomach acid. And guess what they end in? ZOLE, omeprazole, esomeprazole, pantoprazole. So this is one of those situations where you kind of have to be familiar with the differences because that ZOLE isn't going to help. But I will tell you this, that ketoconazole and miconazole, these are over-the-counter strength drugs as well that are used for fun things like vaginal yeast infection, jock itch, okay, and all those kinds of things. Athlete's foot, all of those things are fungal infections. So antifungals will slow down the fungus. And remember, fungi, not like, oh, he's a fungi. Fungi is the plural fungus. Fungi love a dark, warm, moist environment. So when we talk about, how we're instructing patients, if somebody's prone to athlete's foot, maybe because they belong to a gym or they're walking barefoot where they shouldn't be, cotton socks, it wicks the moisture away from the feet. They should not put lotion between the toes because that actually can develop a moist, warm, dark environment and there can be a fungus among us there. Little helpful hints, things that you need to know. We are done with the first 12 chapters. Well, not the first 6 chapters, 6 through 12. And if you have any questions, you can pause, you can rewatch me. Look the meds up in F.A. Davis Nursing Drug Guide, right? Please, and make sure you're focusing on the nursing implications. What do you have to be worried about or looking at before you give the med? And patient education, okay? So the first part of meds, pharmacology, what's the drug, what's it for, right? The second part is, what is your job as the nurse as it relates to that drug, okay? And that's going to be it for now. I've got farm boot camps coming. I've got so much more coming. It's going to be a laugh a minute, and you're going to just know everything you need to know. Talk to you soon. Bye.